Hello to everyone. Just waiting on Michelle to join. Here she is. Hi, Miriam. Hey, Haley.
Hello.
Hey, Michelle.
Hey, it
Everyone's
worked.
coming in.
Oh, brilliant.
Abigail, Gabby, Alicia, Marilena. Lovely. Cindy, hello. Some patients that I haven't talked in months. Very good. Lovely. I'd say we just give them a couple of minutes to see everyone joining in, and then we can sort of start.
Sounds good.
How does the sound like on your end?
It's okay for me. There was a little bit of feedback there, but it's okay just now. Am I all
Okay,
right? Can you hear me okay?
you're great.
Okay.
All right, all right. Yeah, Miriam is saying hello to you.
Hello, Miriam. How are you? Northern Ireland in the house. Love it. Oh, I hope I don't get distracted with all the chats
That
coming
is,
in.
I know. That's why I have my keyboard. I'm sort of gonna hide everything because there's no other way. Michelle Hancock, Anna,
Oh, hi, Michelle.
everyone is joining in. Amazing. Great. So yeah, I think just gonna go give a short summary. So welcome to everyone that's already joined in. My name is Iakovos Georgiou. I'm a plastic surgeon specializing in lipedema surgery, and the lovely Michelle is gonna be joining today as a moderator for our first Q&A session on everything lipedema. It is the first time, so be a bit patient with us. We're sort of testing out the best way to do this, but some really great questions have come in. We're going to try and keep the session to under an hour, so we're going to work through the questions. We also don't want to feel too rushed. It's more of a conversation between myself and Michelle. For those that don't know, I've known Michelle now for years, had a couple of surgeries with me, lipedema reduction surgeries. So I think she's a great patient and person now to sort of guide us through this and moderate the questions and also give her own feedback, give her own input on this because it's all very nice when a surgeon sits there and tells you everything, but I haven't gone through the process. Having someone here that has gone through surgery can be very helpful and sort of give their input as well. Michelle, you want to say a couple of words before we get started?
Yeah, I think I'm just really excited for today. I think this will help so many people that are either thinking about going through the journey or in the journey just now. We've had some really brilliant questions, which I have no doubt will prompt more questions. So I see this as being a starter of a conversation with you. And I think everyone is so thankful that you're being so generous with your time as well to, provide this opportunity for people to ask questions. So I'm excited. I'm excited to be here. Thank you for thinking of me to join you on this. It is an honor.
And thank you so much for moderating. Just going to switch to low power mode. Battery, there we go. All right. So, how about it? You want to start with the first question?
Sure. So the first question, we've kind of got them in a bit of a flow, so hopefully this works for everyone. But the first question is, can you share with us why you chose lipedema as your specialty?
Yeah, I love that question. So I think the first the most common first question I get when I do sessions, it's always the same answer. I was very lucky during my training. I got introduced to a wide spectrum of diseases. Most of you already know that plastic surgery is not just aesthetic surgery; it's reconstructive surgery, it's burn injuries, it's hand deformities. So there's quite a wide spectrum. I think what drew me quite a lot to lipedema through my training under Professor Gotz in Germany. From a very early stage during my training, I got introduced to lipedema. It was something that probably I hadn't even heard of since my studies at university, and even then it was sort of a footnote of a book that you sort of skim through, which is a big shame, of course. It's a disease that can affect so many women worldwide, and still is not enough awareness on the subject. And partly that, but also the major effect that proper diagnosis and proper therapy can have on patients. I think that's probably what drew me to lipedema, and what the reason why it's my main practice focus at the moment as well.
And we're very grateful for that. You know, I think so many people on this call will resonate with a whole mixed emotion, really, of how they've gone through their medical journey with lipedema, of being heard or not supported, etc. So it's very refreshing to have someone like you in our corner helping us navigate this space with just so much gaslighting that's gone on. So I think
Oh,
it's
and
amazing.
I think the average between onset and diagnosis sometimes it's even decades. So this is something that, of course, is not acceptable, and
Yeah,
something that we need to
yeah.
work on.
Yeah. I mean, I was 20 years before I got diagnosis, and it was by chance. I think lots of people will have that story.
And I imagine the frustration just going to the GP or the doctor, and they're just saying you need to exercise more and you need to diet more,
Yeah.
and for a young female patient, most patients get the onset during puberty, and the mental burden that this can put on a teenager, it's can be like scarring for life.
Yeah, traumatic. We talk about that in the group all the time. You
Mm.
know, the trauma that's associated. This isn't just, surgery isn't just an option for the physical changes in your body. You know, we almost go into training for the mental, you know, sort of process of coming to terms with what's happened to us, but also all the changes that happen, you know, as we go through the surgery. So the mental side is just as much an experience as the physical changes that happen with surgery, for sure. One question which then leads on, and we had this question quite a few times from different people, was around how do we recognise the early stages of lipedema, particularly because it's more difficult to tell because it's not as visible for, you know, as it might be for advanced patients. So can you chat us through your thoughts on that one?
So the first sign that most patients report is usually the disproportionality between affected areas and non-affected areas. In very early stages, this can be very, very minimal, but usually patients say that they have been looking at photos going back and they can't see signs after they've been diagnosed. Even at times they did not feel they had so much disproportionality. And the heaviness. We do need to remember that it's very majority of the cases it's with hormonal changes that you have the onset, and even just hormonal changes can cause a lot of the symptoms of something mix the clinical picture and can be tricky. But I think with increased awareness, patients, GPs, gynecologists, all this becoming more aware of the disease, they are starting to pick it up earlier and earlier.
Yeah. And can people come and talk to you about that through consultation if they're not sure or struggling with diagnosis?
Sure. It's because majority of my patients are international. They have been finding a difficult time to getting proper diagnosis or proper treatment
Mm.
back home. It is also possible to just have a consultation if you're not sure about lipedema. We'll go through typical signs, typical symptoms, and even if we decide that it's not lipedema, you still know that there are ways that how you can manage the symptoms that are affecting you.
Yeah, yeah. Can you chat us through what the initial consultation with yourself looks like? So what to expect, what does it include, and is there a charge for your initial consultation?
Sure. So it's pretty much similar to this. Usually a patient will come either through the website or through Instagram, and patients a standardized form, a questionnaire that they need to fill out. To this date, there's no imaging modality that the patient can have to either rule out or make the diagnosis of lipedema. So it's usually through the clinical picture and symptomatology, signs and symptoms. So through receiving photos of the affected areas plus the questionnaire, that's the gateway into starting the consultation process. Once we've received those, within, let's say, 2 to 4 weeks, we'll find an appointment that suits the patient, and we'll start usually a Zoom consultation to go through the photos and the questionnaire together and to discuss a possible treatment plan. And the consultation is free of charge.
Brilliant. And when you're in that initial consultation and you're creating the surgery plan, what does that look like? So what factors determine if a patient is suitable for one procedure versus multiple procedures? Can you chat us through that?
Sure. It's many factors. First, you need to look at the stage of the patient. So lipedema is not one size fits all sort of disease. There's multiple stages, and it depends on the staging of the patient, and depends on the comorbidities, if the patient has any underlying diseases. It depends on also the mental and emotional aspects surrounding surgery. So of course, the more areas you're combining, the trickier the recovery. So you need to be upfront with the patient about that. Of course, traveling abroad for surgery, you want to keep the number of surgeries to a minimum with logistics and costs involved. But you should never compromise neither on the safety of the patient or also it's chatting about the patients and making an individualized plan for each one.
Yeah, I think it's great that, you know, through that consultation, really starting to get a flavour of what that plan might look like for the patient so that they can then start to think about, well, how long might I want to stay in Cyprus, for example? It's a question we talk about a lot in the group, for example. You know, and I know it's very individual for everyone, but just from my own experience, I always think the longer you can stay here, however long that period is, the better, because the care and the support through that recovery process, especially the early days, is just so important.
For sure. Ideally, patients stay, let's say, 2 weeks after surgery. I think that's ideal. Of course, life goes on even apart from surgery, and sometimes we cannot avoid needing to fly back home sooner. The important thing is clear communication between
Yeah.
me, myself, my team, and the patient. So even after the patient flies back home, they have my personal WhatsApp number, they have my email, they have my team's contact information, and we're reachable in case of any issues. In regards to the primary consultation, I think you're also a great example of it does need to stay a bit dynamic. So we do need to be having some flexibility as we go along, because as the body changes with lipedema reduction surgery, sometimes the perception of the patient and the outcome, the goal of the patient changes as well. So
Yeah.
I think chatting about it and knowing, okay, this is the first surgeries, especially in advanced case lipedema, they're more functional, they're more debulking. Maybe as we go along, I will start looking more into aesthetics. That's definitely something that the patient needs to be aware of, even if they're not thinking about it absolutely at the beginning. That might become more and more important in the end.
I'm smiling because that absolutely happened with me. You remember those early conversations where I was just like, no, I just want to be rid of the lipedema. I'm not thinking about aesthetics, and it's amazing how quickly it creeps up on you. I think you don't realize the impact with each debulking surgery you have of all of a sudden hopes and dreams and wishes that you hadn't dared to have thought of before starts to become more of a reality. So I think it's always good. And I certainly talk through that with people that I speak to, is about dare to think about the aesthetics, because it's going to come, and you know you will be faced with it sooner than you think.
Mm, yeah, I
Mm.
agree.
So we have some other questions that are coming in around just some wider considerations for surgery. So the first one, and again, this was asked a few times, is high CRP levels connected to lipedema, and how high is too high if you do have high
Sure.
levels?
For sure. Great question. We also did a retrospective study, which basically means we went through our records for the first 2 years at our center, and we did show that the majority of lipedema patients did have an elevated CRP. This is something that we had suspected. That was our working hypothesis. We know that there is an inflammatory process in lipedema. CRP being elevated is a sign of that. We also found that there was a connection between how was the stage of the disease. Higher stage patients did have a higher level of CRP. The hope is we're trying to expand the study to show that with lipedema reduction surgery or even the GLP-1 medication, I think that's a wonderful area that is also very, very important now for lipedema treatment. We're hoping that through proper treatment, you're normalizing CRP or bringing it down. But yeah, how high is too high usually depends on the laboratory as well. If they're using per test, the 1 to 5 or up to 0.5, so it depends. But usually what we see in lipedema in advanced cases is double of the normal. So if it's 5 milligrams per deciliter, usually it's about 5 to 10, let's say, something like that.
Yeah. I know in my case, my last round of bloods I had before my last surgery, my CRP was in the normal range for the first time in my life. So interesting, I always think. Someone's asking about blood pressure. So they have blood pressure that is at the low end of the healthy range. Is that a problem for surgery?
Sure. Very interesting question, very important question. And it's very, very common that especially young female patients do have a tendency for low blood pressure. And this is usually accentuated, so it gets worse after lipedema reduction surgery. We're talking about large volume liposuction. We're talking removing up to 10% of the patient's total weight per volume. So that's why one of the reasons why I do my surgeries in general anesthesia with the anesthesiology team by the patient, the entire procedure, taking care of the blood pressure. But that the problem doesn't stop there. Even after surgery, for the first couple of days, we do have a tendency for low blood pressure. That's why I'm keeping the patients in for at least 3 days. You need to give IV fluids. You need to be checking up on the electrolytes of the patient, sodium, potassium, to see if we need to do some substitution to bring the blood pressure back up, and only discharging the patient once they're able to do so. So yes, there are considerations with low blood pressure, but having low blood pressure is not an exclusion factor for surgery.
Good. Okay. And then there's a couple of questions. I just saw one coming in the chat as well. If people have rheumatoid arthritis or osteoarthritis, has anyone had surgery with this condition, and what does recovery look like?
Sure. Both cases, yes. I've had patients with either rheumatoid arthritis or osteoarthritis. It's a different disease pattern for these two diseases. Just as a short summary, rheumatoid arthritis, very often this is an autoimmune disease, and these patients are sometimes on either biological therapy or cortisone or methotrexate. So that's one consideration that you need to be looking into, which medication they are on. Some of these medications can have an effect either on the wound healing or on the infection risk. So what I usually do is either myself coming into direct communication with the rheumatologist of the patient to discuss the case, or the patient chatting with them to see if there's any changes to the medication, increasing, lowering the dose, stopping before surgery or after surgery. So again, communication here is very important. Also need to be aware, as also with osteoarthritis, the longer you're keeping the patient immobile after surgery, the worse the symptoms will get. So you do need to be very, very much promoting early mobility, as we do with all patients, of course. Swimming, hydrotherapy, aqua gym, as soon as all wounds heal, that's excellent, especially in rheumatoid arthritis. But again, each patient is different, so you do need to have a look at everything and discuss with the patients the proper treatment plan. Osteoarthritis definitely much more common. We see it, and I would go as far as say maybe the majority of advanced stages over 60 years old. So, and it is one of the recognized secondary comorbidities of lipedema. And it's not just the bulk of lipedema around the joints. It's also the fact that Michelle, if it's okay to mention, you sometimes bulk of tissue sort of creates a difference in the posture, a change in the posture of how you walk and how you stand, and that can predispose destruction. So while lipedema reduction surgery cannot fix osteoarthritis, it can definitely stop its progression, slow down the progression, improve the symptoms. And in multiple cases, I've had patients that were a candidate for knee replacement or hip replacement surgery, and the orthopedic surgeon basically denied the surgery because of the lipedema. So I've had patients that needed to go through the lipedema reduction surgery first to be able to go through replacement surgery. So yeah, definitely a multifaceted disease.
Yeah, I just when you mentioned my case there, I certainly noticed. I call it, it's almost like growing pains, as my posture has completely changed. So my hips almost are trying to find where they should sit now, compared to where they might have sat before with, you know, my gait, and I had a really bad back shelf. So it's almost like growing pains as my body trying to figure out how it is supposed to move with my new size and mobility.
And this can take months, and the back shelf as well. It doesn't get talked about enough. Many patients don't even realize it, but having several inches of fat over the sacral bone, it creates such a huge difficulty in sleeping, standing, walking, even swimming. Or so, yeah, you do need to be looking at the patient holistically and decide the best way to help them.
Yeah. Lovely, thank you. And someone's asked here, can someone with factor V Leiden still have lipedema surgery?
Yes, factor V Leiden, for other patients, other people in the audience, it increases the risk of a blood clot. So definitely important to be aware of it. We do take as many measures as possible, even without this predisposition to blood clots, to avoid the blood clot, because that's one of the dreaded complications that you don't want to have. So all my patients receive anti-blood clot injections 6 hours after surgery, and we continue the injections until they're safe back home. Sometimes it means 2 weeks, sometimes it means 3 weeks. It is rare, but it can happen, so you need to take all the steps. Um, if factor V Leiden again doesn't exclude the option of surgery, but definitely need to have a thorough history and discuss any types of changes in the standard that you can do. Some patients, for example, um, need to start with the injections even before spending from Australia. Like I have a very long flight ahead of them, so before the surgery, for the long flight, they do need to start with the injections. And yeah, again, chatting with the patient to find the best way to deal with that.
And what about if someone has visible thread veins on the back of their knees? Do they need to be assessed or treated before surgery? And can that affect someone's suitability for lipedema surgery?
Again, it's different veins, spider veins, chronic venous insufficiency, varicose veins. I know there are many lipedema surgeons that need patients to have the vascular system treated first. I do not have this prerequisite. I feel, while yes, the two systems are very closely related, they are independent, and you need to treat them as such. Again, case by case decision. And I even had patients with chronic venous insufficiency lipedema reduction surgery first, and after lipedema reduction surgery, they had another ultrasound, and chronic venous insufficiency was basically treated without having so I'm not saying this is a rule of thumb for everyone. I'm just saying it's a case by case decision, and me myself don't necessarily need you to address either varicose veins or spider veins before lipedema reduction surgery.
Okay, brilliant. I see a chat question coming in the chat as well. So I'm keeping an eye on those. I'll bring those in a wee while too. Someone's asking about the surgery. So can it be performed with local anesthesia rather than general? Can you chat us through the options for that?
I would say it is possible because I know there are surgeons that do that. Through my training under Professor Gotts, I got introduced to general anesthesia, lipedema reduction surgery, and that's definitely what I feel most comfortable with. So I that's my treatment standard. I would say if a patient is dead set on having this in local anesthesia, then probably best to be consulting with a lipedema surgeon that specializes in that. I think it's always a good idea to have a couple of consultations with multiple lipedema surgeons to see what makes more sense for you, what is a better fit, and what you feel most comfortable with. I myself, with the technique that I'm using, that definitely would be general anesthesia.
Okay, thank you. Um, when we're starting to think about preparing for surgery, and wanting to get the best outcome that we can get, what's your views on using collagen to help with loose skin?
Sure. Collagen. So in medicine, we like to work with evidence-based medicine. So basically means that we're having studies, we're having publications in peer-reviewed journals. They tested something and they show the benefit of it. As far to my knowledge, of course, medicine is changing on a daily basis now, but as far as I know, there's no big studies showing the benefits of collagen. I know some patients have even raised the concern of, we say that lipedema is a collagen-based disease, and why would I be taking collagen to treat a collagen-based disease? That might be a bit simplistic, but at least I don't have enough information about benefits, yes or no, to be advising that to patients. I had patients in the past, and they did report that they saw some benefit, but again, for me personally, I always prefer to have publications, evidence-based medicine before making a decision on suggesting something. So I think the jury's out on that one.
Okay. Um, is there ever a case where you think someone is too far gone with lipedema? Their lipedema is so advanced that they can't be helped by surgery?
I don't think that's the case. I think it doesn't mean that I don't sort of refuse surgery in some cases. That's not because of very advanced case, though. That's usually because of maybe motivation of the patient. I think that would probably be the biggest aspect in that. It's important to remember that what we do as surgeons, it's the easy part of the treatment. It's 3 to 5 hour surgery, and that's it from us. Biggest part in lipedema therapy, both conservative and surgical, is from the patient's point of view. So even after surgery, lifestyle choices, healthy nutrition, physical activity, sometimes even compression garments, they are important. They need to keep it up. In some cases, you need to increase your physical activity. You need to use the boost that you get in your physical, in your mobility, in your exercising capacity, in your confidence to sort of work with what we achieved with surgery. So that would probably be a bigger factor for me, thinking that the patient was not a good candidate for surgery, that rather than being a very, very advanced case.
Okay. I think it's a really good point, actually, and it's something that I've learned more and more as I've gone through the journey, how much of a team effort it is. When you think about it, there's, the extent of the involvement from yourself, there's the work of Dr. Yolanda, there's Christos and all the amazing support he provides. And I probably underestimated on my first surgery, certainly, how much work I also and how much I needed to show up for myself, both physically and emotionally through that journey. I probably didn't anticipate or maybe hadn't prepared enough for that in that first surgery. It gets easier with every surgery, of course. There's so many unknowns on that first one, but it definitely takes a village, as they say. And that's one of the biggest lessons that I've learned. We talk about that in group a lot as well. Just even the support from other patients is massive in your recovery.
For sure. And you are definitely a great part of that as well. The process here, I don't know if people know this, but Michelle, she was one of the first patients to come for surgery here, and she began the WhatsApp group of patients traveling for this kind of surgery, sort of join in and they support each other, and having the support of not just my team and Dr. Yolanda and Christos, which are amazing, of course, but also of each other, and sort of chatting between them to understand the whole process has been a huge help in helping them prepare for surgery, not just physically, but emotionally and mentally as well. So thank you very much, Michelle.
Oh, it's not just me, it's that whole group, to be honest with you. I get as much from the group as everyone else because I think when you've been isolated and probably feeling alone for so long in this journey, the power and the support and the inspiration that you get from everyone in that group is phenomenal as you prepare to go for surgery. When you're in Cyprus, we call it the Cyprus bubble. You know, there's patients on the group here that we talk about it a lot. That it definitely, there's no doubt in my mind anyway, that it helps with recovery. It's so crucial and important to feel that community spirit of togetherness, isn't it? If you don't feel alone, everything feels much easier.
Exactly.
Yeah. Just a couple more questions that had come in the chat that I was keeping an eye on there. There's someone that's watching us tonight that's had surgery with you in Germany. So the question was just, do you do things differently at the clinic in Limassol to what the protocols were in Germany, or how does it compare?
Sure, of course. I was in Germany for many years. I worked with Dr. Gotz, under Dr. Gotz, for many years. I got excellent training from him. I got introduced to many different kinds of devices using in lipedema reduction surgery. Of coming back to Cyprus, the first thing I said, all right, what now? How do I apply everything that I learned? So I thought, all right, so do what you learned. And so I chose to do this in a hospital setting. I think that's paramount, especially when you're dealing with lipedema, advanced stage lipedema, when you're removing 10% of a patient's total body weight per surgery. You do need to have that safety net, especially for international patients. They need to be sure that they're covered in whatever issue may arise. That was the beginning. Having come back to Cyprus, there were some things that were different from Germany, such as maybe the necessity for an aesthetic outcome might be a bit higher. I think it's because warm country and having a higher expectation of what to expect after surgery. So I did need to look into more skin tightening devices. That's something that I'm doing differently than during my time in Germany. For example, now I'm using, in the beginning I was using Morphusate. Now I have also Renuvion, which is better for mild to moderate skin laxity. Power assisted liposuction is still my preferred technique in lipedema reduction surgery. My career, that's what I was primarily using in Germany as well. I do have Vaser, and I selectively use it in specific areas when I'm doing lipedema reduction surgery. So it is a combination of techniques, and it has evolved, I would call it, during my time in Germany. It's just what I feel most comfortable with to achieve the best results that I can for myself.
And you'll talk all that through with the patient as part of
Of
the
course,
surgical plan so that they understand what techniques you'll be using.
of course.
Brilliant. And then in terms of your waiting list just now, how long is your waiting list for patients?
Sure. So there are a few slots left over the summertime. The reason for that is, and I'm sure Michelle can attest to that, it can get quite warm in the summer. Conference after surgery is very difficult. That's why I always advise all my patients to start wearing them before they make the decision of going forward with surgery, because you need to be wearing them day and night 6 weeks after surgery. So there are some slots left in the summertime after September 1st. Everything is quite full until beginning of February or so. Um, there is a cancellation list, and patients are always free to join the cancellation list, and it depends on their flexibility, of course, as well. I'm sure we can find surgery dates that fit most people's schedule. They just need to come into contact with myself or my secretary to be put on the cancellation list.
Brilliant. And in terms of the hospital stay then, how long do you recommend for the hospital stay post-surgery?
So our standard hospital stay is 3 nights. The reason for that is we do keep the drains in. We place very small drains in some of the incisions for 3 nights. On the third day, we remove the drains, and the leaking from the surgery might not completely stop, but it's getting definitely much better. And that makes the patient also more comfortable to be discharged. We do have an option for staying longer, such as 5 nights. It's always pros and cons, though. Of course, staying in hospital might seem more comfortable in the beginning, but as the days go by, patients do start to get a bit bored, I would say, in the hospital. Plus, the level of mobility might not be ideal. These kinds of surgeries, the lymphatic system, you need to reactivate it. Mobility is very important in doing so. And with being discharged in a nearby hotel or even an apartment, if you're coming with someone, does give more mobility than you can probably achieve at the hospital. So I would say ideally, or the standard would be 3 nights. Of course, no one would discharge you unless myself or the patient feel 100% ready to do so. But it's again case by case decision.
Yeah. And I think as you go through your surgery journeys, you get more confident to know when is the right time for you to leave the hospital, don't you? I always say in my case, I'm always better out than in, because you're back in your own surroundings, you can get back into your own routine, that kind of thing. So, but everyone's got different cases. So, like
For
you say,
sure.
it's important to make sure everyone feels comfortable with that decision.
Exactly, absolutely right. And again, I mean, I even had a patient from the get-go. We decided on 7 nights together. She had POTS, so a bigger risk of like low blood pressure and dizzy spells. So you need to take all things into consideration. You need to be sure that when the patient is discharged, they are safe. I think the fact that the MLD team, Christos, Marilena, they are visiting the patients daily at their hotel. So, a patient, someone from my team is seeing you daily. You have my personal WhatsApp number. You know the GMI is open 24/7. I think that does give a big security blanket to patients, but each patient is different and you need to treat it so.
Mm. Security blanket is the right word. I think having that contact with Christos, again, it's something I maybe underestimated how important that would be to have that connection with him. He's so attuned with not just the physical needs of MLD post-surgery, but even little things, he'll notice dips in your mood or, if you're particularly struggling with things, he's so highly emotionally intelligent and aware of where we are in the recovery. It goes back to that point I was making earlier of the importance of the team and having that contact every day once you get out is such a comfort knowing that you'll see him and he'll aside from bringing his witty banter, he provides a level of comfort as you start to navigate what does recovery look like for you. It's a massive part of our recovery as well, having Christos in the team come and
For
see us every day.
For sure. This wouldn't work without Christos, without Marilena, the rest of the physio team. It's the only way. As I said, the surgery is on a small part of the treatment. The before and the after are equally important, and you do need a team to be able to offer this level of comfort to the patient.
Yeah. And so talking of MLD then, can you chat us to what the requirements are for pre and post surgery MLD?
So that's a bit of a tricky question, especially for the pre-op. So if we're dealing with only lipedema, we need to remember that lipedema and lymphedema, while some usually separate, they can coexist, especially in advanced cases. So if you're dealing with, strictly speaking, lipedema, I think having 1 or 2 sessions the weeks leading up to surgery, that's sufficient. I still believe it's a good idea to have at least 1 or 2 sessions with your team back home, because you do need to remember that when you get back
Mhm.
home after surgery, they're in a huge part of the recovery process. So they do need to get accustomed to the tissue. They need to get used to working with you and you with them. So that's very important. Of course, if we're dealing with lymphedema, MLD is more important. So maybe even 1 or 2 times per week before surgery. Again, get case by case decision and something that we can discuss together with the patient. Completely different story for after surgery, though. After surgery, all patients extremely important. I would say ideally 10 days after surgery, daily MLD. That helps quite a lot to get you to the best condition possible before the flight back home. After you get back home after week 2, week 3, 2 to 3 times a week until week 6 is usually sufficient. It depends on your mobility level, on your predisposition to swelling. It depends on many factors. What I also love after surgery is, as I already mentioned, swimming, hydrotherapy, aqua gym. After week 4, week 5, when the scabs fall off after surgery, that's a huge step forward in your recovery process, getting rid of any residual swelling. But again, this is something that you need to be discussing either with myself or your MLD team back home to decide the best time point to do this.
Mm. I just saw Cheryl put a question in as well around, is the GMI thinking about hyperbaric oxygen therapy as part of recovery? Is it recommended?
It's not something that I can promise at this moment, but we're definitely looking into it. We've had multiple patients that have used it in the past, and there are multiple publications coming out showing the benefit of HBOT in post-op recovery. So I find it's a very, very interesting aspect. I'm hoping that's something that we can offer our patients, but as you can imagine, there's logistics. It's an ongoing process, and I'm hoping to be able to give you an update very soon.
And a couple of questions in the chat's been coming in around compression, pre and post surgery, and also can you recommend class and type of compression that would be needed? Now it's
Sure.
quite a difficult one to answer because it depends on
Yeah.
body parts, etc. But if we could just talk generally around that, what's your
Okay.
views on it?
Sure. So generally, yes, we need to remember that the first line of treatment in lipedema is always the conservative treatment. Very big part of that is the compression garments. So all patients, before making a decision to go forward with lipedema reduction surgery, they should go through a process of conservative therapy. This can mean 6 weeks, it can mean 6 months. It very much depends on the patient, what their hope from therapy is, and how the conservative therapy is going. That's the first aspect in this. We also need to remember that the compression garments are not just part of the conservative therapy, they're an important part of the preoperative measures that you need to prepare for surgery as well. So a few patients that I can remember that maybe did not follow the pre-op measures very, very correctly. They were not wearing the compression garments during sleep, for example, before surgery. They had a very difficult time of wearing it after surgery, so they were not very used to them. So that's another factor that we need to weigh in. We need to remember that conservative therapy compression garments can sort of soften up the tissue, makes my life easier during surgery, improves the outcomes. Another great benefit of compression garments. Now, in regards to the type of compression garments, as you said, complex subject. I think the standard still remains flat knit class 2 compression. When we're dealing with the legs, I do prefer the ones that come all the way from the foot itself up until the belly button, so the legging, the entire surface of the leg. Some cases, patients prefer to go open toe, closed toe. I prefer open toe, but I can work with both, open crotch, closed crotch, benefits and pros and cons with each one. Again, best to decide directly with the patient. Um, Ready-made ones usually are a better option for earlier stage patients. Advanced stage patients often have a problem of one area sitting nicely in ready-made ones and
Mm.
another not so much.
Yeah.
In those cases, maybe custom-made ones are better, but of course, custom-made ones are much pricier. Not all countries, not all healthcare systems offer them
Mm.
free of charge. So again, it's chatting with patients to decide what's the best for them at that specific point. And we do need to remember that maybe not right after surgery, but within a few weeks, you might need to be downsizing. So again, you need to be discussing with about this with the patient directly.
Yeah. I have to say it's probably one of the hottest topics in our WhatsApp group. In fact, we had to create a separate channel for it. There was so much chatter back and forward around types of compression, different types of class. And it's constant. The conversation around compression and the difficulty of getting compression that fits is challenging for everyone. Um, I'm conscious of time, but could we ask a few questions around legs specifically? We do have a
Sure.
number of other areas as well that we'll talk about probably in future lives because I'm conscious of time tonight. But if we were to just go through a few questions in terms of legs, do you tend to do front legs first always as a
Sure.
surgical plan?
So I would say maybe 9 times out of 10, I start with front legs first. So again, for patients that are not used to this, and stage 2, stage 3 patients, you do need 2 or even multiple surgeries. And there are surgeons that prefer to do 360 lowers and then 360 uppers. Again, different techniques. From my training, I got introduced to fronts first, backs later, or the other way around. There's a couple of reasons why I prefer doing this. I feel not needing to change patients multiple times during surgery. That decreases the surgical time, makes the recovery easier for the patient, and lowers the cost for the patient. That's the one thing. Starting with the fronts, the reason why I prefer that, it gives me the option of working on the groin from the beginning, sort of debulking a very a very rich lymphatic rich area. So the lymphatic system can sort of be decongested, helping with the recovery. And I do feel maybe you can give your input as well, Michelle, that maybe fronts tend to be a bit easier than the backs. It's difficult to know because you go through one or the other first, so it's difficult to compare. But I have a sense that the fronts tend to be a bit easier, sort of easing the patient into the whole treatment option. What do you think?
Um, It's really, we talk about this a lot as well. In my case, my fronts were easier than my backs, but lots of people say that their backs were easier. And I think it can depend on volume, it can depend on the individual patient. I think we're probably more prepared by the second one as well. So I would say for as many people that would say the fronts are easier, there's probably as many that would say the backs are easier. There's so many different factors to take into account with it all. But yeah, it's it's a hard one to answer. It's very personal, isn't it? Everyone
Oh,
experiences it differently.
yeah,
Um, just thinking about this is a specific question about stage 2 patients. So you have someone that's scheduled to come for front legs, and the question is, do you need to decide about using skin tightening like Renuvion straight away, or can it be done later on? So should you be doing it when you're getting the front legs done, or could you do it later?
sure. So I think it's always best if you need to do Renuvion, if we, during the pre-op consultation, I feel that might be an issue, skin laxity might be an issue after surgery, then I would prefer to use it from the very first procedure. It also depends on the timing of the second surgery. So if we have 3 months in between surgeries, I might be a bit hesitant on going with the Renuvion within 3 months of areas that I treated 3 months ago. Uh, I'm not excluding it, but I would feel I would be getting better results, and it's also safer if we are doing it from the beginning.
Mm,
Plus, another problem would be that it would turn you over during surgery when it's increasing the surgical time and it's increasing the surgical cost as well. So, from a cost-effective point of view, it's always best to be doing it from the first procedure.
mm,
If you are interested in doing it only for one of the two procedures, the Renuvion, then probably more important to do it for the fronts. Usually the inner thigh and above the knees, those are areas that patients find they're not 100% happy with sagging after lipedema reduction surgery. Of course, it depends on the amount of fat that you're removing and skin retraction capabilities of the patient. But again, this is something that needs to be discussed with the patient.
Yeah. And just thinking of that similarly for thigh lift for patients that may have had two leg surgeries, how long should we wait in between, or what is your general approach for thigh lifts?
I would say I would wait at least 6 months after lipedema reduction surgery to move forward with the thigh lift. Of course, a few weeks up and down doesn't make a huge difference, but you do need to allow first the tissue to sort of recover fully, and you do need to allow for good skin redraping. So sometimes I don't know if you've seen before afters of patients that had just the fronts or just the backs. If you wait like 3 or 4 months of just doing the fronts and you take a look at the backs, you notice the difference on the backs even without touching them. This is because of the skin redraping, sort of the skin going to the area of less resistance. So you do need to allow for this to take place so that you can plan your thigh lift better. I
Mm,
would say in between 6 to 12 months is good.
mm. The in-between stage, as I call it. No one
Exactly.
talks enough about that.
Yeah.
Um, and then there's a question around if people are having 360 for their full legs. So would you consider carrying out 360 ankles to knees and full arms, and then 360 upper legs and lower abdomen?
Yeah.
Would you ever consider that?
Sure. So, doing arms and legs during the same procedure is extremely difficult. Not so much for me, but A, for the patient, and B, for the anesthesiology team. For the patient, because wearing compression garments, arms and legs at the same time is horrible. I think you can attest to full body compression.
Don't do it.
And yeah, and for the anesthesiology team as well, they do need one extremity at least for access for the IV. So I would be a bit hesitant on doing arms and I've done it in the past, and I think both me and my and the patient would say probably best to avoid it if possible. So I would prefer to deal either arms with belly or legs alone. I I do have the option of doing 360 legs and mons or minimal liposuction to the belly as well. But again, it depends on the 10% limit. It depends on the skin condition. It depends on the amount of liters needing to remove.
Yeah, I can attest. We were laughing at dinner the other night because I was saying literally it was only my wee cheeks that were not exposed in compression. One thing I would say about it is if you are going to do multiple areas, you probably should get in training for wearing the compression because it's harder than you think to be in a lot of compression, especially depending on the time of year that you're here with the heat. It's tough wearing a lot of compression on your body.
Yeah, for sure. Again,
Um,
the fact that with the WhatsApp group and patients talking with each other, I think this gives a good patient's input point of view as well.
yeah, yeah. Gabby's just asking a question there while we're talking about compression. If you keep it on, oh, it's just moved. If you keep is it better to keep compression on longer than 6 weeks, to help with better skin retraction?
Sure. So again, as I said, evidence-based medicine, we prefer to have publications to make a decision. There's no one publication showing that wearing compression garments longer will help in the skin retraction. It does stand to reason, especially as long as you're having even minimal swelling. We do need to be activating the lymphatics as well, so we do need to the lymphatic system do its work as well. I think at the 6 week point, it's always a good time point for the patient to sort of reach out to me, and we'll chat about where we are in regards to swelling and any
Mm.
pins and needle sensation, anything like that. At that point, might be a good idea to start sleeping without the compression garment and having them on for a few more weeks at least daytime. There are other options as well for skin retraction. What patients have told me, some patients choose to do more weightlifting, more weight training as well. The increased muscle tone can help a bit, not with the skin retraction as such, but the appearance of more tight skin. So yeah, again, it's a case-by-case decision. Wearing compression garments longer than 6 weeks is okay, but we don't want the patient necessarily to stay in compression garments for 12 months. I
Yeah.
think that would be a good summary of the answer.
Thank you for that. Just a couple of quick questions. I'm really conscious of your time. Karen was asking about when you spoke about the wait for thigh lift. So waiting to get your thigh lift done. Is it the same wait for all stages? Or do you have different wait length times for different
Sure.
stages?
So to be very honest, I would say 90% or 99% of the cases that do need the thigh lift are stage 3. So we are mostly dealing with advanced stage lipedema. So stage 1 almost never needs a thigh lift. Stage 2, uh, majority of the cases we can get away with it with Renuvion. Of course, it depends on the final aesthetic expectation of the patient. I think 6 to 12 months is a rule of thumb for all stages.
Okay. Um, And then a question has come in that has a couple of questions within it. So bear with as I read it through. So fat transfer to hip dips,
Yeah.
is that yay or nay for you? And if it is a yes, then what is the best type of compression for that area?
Sure. So, for patients that are not aware of the topic of fat grafting and lipedema, so lipedema surgeons, lipedema specialists, we're advocating that lipedema is a disease. Lipedema fat cells are pathological, or in one way or another. Then why would we take them from one body area and graft them into another? Maybe risking the symptoms appearing in the grafted area. Having said that, through multiple reconstructive procedures in patients with lipedema, for example, reconstructive breast surgery, sometimes you do need to take the risk of grafting even in lipedema cases. In all the procedures that I have performed, and my Dr. Gotz, we had this discussion during my time with him as well. Neither myself nor other lipedema surgeons have seen a recurrence or an increase in symptoms in grafted areas. Again, though, we like to work with publications. Still to this day, there's no publication on the safety of fat grafting in lipedema patients. During last year's International Lipedema Conference in Rome, it was one of the topics that was very much debated, and a couple of surgeons said that they are in the process of publishing their data to show that it is safe, it is possible to do. To my knowledge, the publications are not out. So I think honesty and transparency is important in this regard. If a patient is interested in this, you need to be mentioning the risk of maybe when we do the fat grafting, the grafted fat cells, we will have symptoms there. I've done it in the past. I haven't seen that in my practice, but I cannot exclude it because I don't have the studies, the publication to back this up. And we decide together if it's a risk worth taking.
Thank you for that. I'm very conscious of time and the fact that you have surgeries planned for tomorrow. Just one quick question, just to finish off. And I think we probably should talk about the fact that we still have quite a lot of questions. Everyone was so brilliant at sending in their questions, and they're all need to be answered. So, but if we could just finish off with one question tonight, which
Sure.
has just come into the chat. Are you finding lipedema throughout the entire body?
Another very hotly debated subject that is thankfully getting more and more traction. A wonderful publication came out from the amazing Dr. Bruno, a brilliant lipedema surgeon and great guy as well, discussing lipedema nodules, lipedema findings in the lower abdomen as well. This is something that we're seeing more and more. I think we're learning something about lipedema almost on a daily basis. I think staying with the strict definition of lipedema occurring only on extremities might be a bit simplistic. I think we need to keep our eyes and ears open. We need to listen to our patients saying that they feel the nodules, they feel the pain in other places as well. To keep an open mind and do more research so that we can perhaps change the definition.
I like the idea of keeping an open mind. We talk about it a lot in the group around, that actually there's a lot of evidence that patients have, through their own lived experience of, I know in my case, I can feel nodules in my boobs, for example, so I think keeping an open mind in absence of research just now until we get more investment into understanding more about the condition, I think is great. And, it's one of the things I'm most grateful to you for, because you've talked me through all of this with each of my different consultations on the 5 different surgeries that I've had, just to help me navigate that space on my own, because it can be really difficult to navigate it when everyone's saying no, it's only your legs and your arms, or it can be really difficult and disheartening for people. So having that open mind and someone that's listening to you through that process is gold dust in my view. So thank you for that. I'm really conscious of time now, so is it worth just talking for 1 second about what we will do with the questions that we have left, because they're too good not to be answered?
Sure. I'm sorry to the patients that we didn't manage to go through your questions, but we do have the list. So the plan would be in the coming days or weeks, I'm going to be posting on my Instagram answers as a story to your questions. So keep having a look on our social media. We will be posting this session as well in the coming weeks. So for the patients that were not able to catch all of it, to have a look. And I'm very much hoping that this is more of a regular thing. I'm not sure if you can do this on every 3 months or every 6 months. We'll see though. But yeah, I'm happy to be seeing my patients and chatting about any questions we might have.
That's amazing. That's amazing. Well, thank you, everyone. The questions have been great, and I know this will help so many people. So thank you again for your time, Dr. J, because it's such a big decision to make to go forward with surgery. So getting opportunities like this for people to ask their questions is just amazing. So thank you.
Yeah, thank you to everyone that joined in, and Michelle, thank you very much, not just for this, but for everything. And yeah, I'll see you very soon.
See you soon.
Good night, everyone. Bye bye.
Thanks, everyone.
Bye bye.